patient?
I have this person.
Okay. Let's keep moving.
This is an 81-year-old female who has a past medical history of AFib, cellulitis, an abscess of her leg, congestive heart failure, type 2 diabetes, hypercholesteremia, hyperparathyroidism, hypertension, and schizoaffective disorder. And she had an operation earlier in this week, and nothing happened overnight. Her temperature ranged from 36 to 37.2 degrees. Her heart rate was from 91 to 130. Her respiratory rate was 18. Her blood pressure ranged from 115 to 154 over 59 to 78. Her oxygen ranged from 96% to 99%. She had 660 of PO and 1.8 liters of urine out. Her labs, I don't know what her BNP was. Her CBC looks pretty good.
A couple things about your presentation, okay? First of all, this is your education. I'm a firm believer that in 2 years, this will be you rounding on these patients and these patients will be yours. So I want you to learn how to take care of patients properly and how to get through rounds very efficiently, okay? We only have a few minutes to spend with each patient because we have over 30 patients on the list, and we don't want to be here at 4 o'clock in the morning rounding, so we have to be very efficient with our time. So the first thing that we need to go over is past medical history. You and I have seen this patient for 5 days now. We don't need to know the past medical history. We've learned her past medical history. We understand it. Second thing is you were in her operation, okay? So instead of saying this patient had an operation, why don't we list out the operation that the patient had and just think about, any of the complications that occurred with the operation, if any did, and just keep that in mind when you're going over your plan, okay? The next thing is vital signs. So I don't need to know the vital signs, the range of the vital signs. You listed the range of the vital signs, and we just need to know the highs, the lows, anything abnormal, okay? Make sure that we can go over at another time the different abnormalities with vital signs, but we need to make sure that we're hitting the highs and the lows and being efficient with our time. Next thing is drain output, urine output. We need to make sure those are separated and listed out appropriately when you're presenting. And then for labs, I understand that sometimes phlebotomy isn't able to collect the labs before we are rounding because we round so early, so that's okay. But if labs are collected and resulted, make sure that you're presenting those in your presentation, okay? And then last thing is just for plan. I understand that sometimes it's hard to know the next steps for these patients that have really complex procedures, but just always think about what the next step would be for the patient. Even if it's the patient's having some wheezing, we could maybe give them some Lasix to help with pulmonary edema or a chest x-ray, or if they've been in bed for 3 days and haven't gotten out of bed, maybe some physical therapy to help them move along, all right? Do you have any questions about that?
No.
All right, next patient. Who has the next patient?
I have her.
Great.
This is an 81-year-old female. She's post-op day 5 from a left below knee amputation. She had no acute events overnight. She was afebrile. Heart rate ranged between 91 and 130. The 130 was overnight before pain medicine, and she's 98 this morning. Her blood pressure was normotensive, and her oxygen saturations were above 96% on room air. She took in 660 of PO and had 1.2 liters of urine out in the last 24 hours. She has 2 drains. The lateral put out 20 cc's and the medial put out 10 cc's in the last 24 hours, and her drain output is serosanguinous. Her labs this morning, her BNP is unremarkable. We've been watching her creatinine and it's been stable at 0.9. And her CBC, her white count's 8 and her hemoglobin is 10. Those are both normal for her and have been stable. My plan for her today is to change her from a PCA to oral pain medicine, since this morning she was not complaining of much pain, and to continue her antibiotics for a couple more days.
Great. That was a really good presentation, Ursula.
I liked how it was very short and sweet, and it was very concise. You hit all the key points that we would want to know in the morning. And I really liked how your plan was very systematically presented. You went through all the systems, neuro, cardiovascular, pulm, GI, and that's exactly what we want from you. So thank you. Good job. Keep up the good work.
Hi, I am Ursula Adams, one of the second-year general surgery residents.
Hi, I'm Audrey Corey, one of the second-year cardiothoracic surgery residents.
I wanted to talk to you a little bit about what it's like on surgery rounds in the morning and what you can expect on a surgical service, because when I was a med student here, I was very intimidated by the surgery department. I did not want to do surgery, and so I can empathize with going into surgery and feeling not used to the presentation style and the vibe of the surgery department. So just some tips so that you can do well on your surgery rotation. The mornings, we get here very early and we have a lot of patients, and some of them are complex and they have different issues. And the way to give a good presentation is to be concise and to highlight the high points, meaning the important things that can change the course of the patient from day to day and what can help them move towards discharge from the hospital. So if they're hypotensive or they're not eating enough or they're not walking enough, those are all things that you can talk about in your presentation plan for things that we can change. And in terms of listing labs and vital signs, you really, as Taylor said in the feedback portion, want to talk about the most pertinent ones or the outliers that we would be concerned about. Surgeons and surgery chiefs like a lot of numbers and data, so looking up the drain outputs, if there are separate drains, knowing which is which, knowing the exact urine outputs, knowing the exact labs, giving those numbers directly rather than just words like soft pressures or a little bit hypotensive. Giving the actual numbers will set you up for success.
And to add on to what Ursula said, a lot of times we care a lot about trends as well. So you say someone's hemoglobin is 8.4, sometimes you can say it's stable at 8.4, or it's 8.4 down from 15, and that's dramatic, and we would like to know about that because trends are important. Somebody's baseline hemoglobin might be low, and so just things to think about. And then when we give feedback, sometimes we tend to be more direct than some other residents you may work with, and that's not because we're trying to be mean or anything. It's just because we're up early. Rounds are before going to the OR at 7:30. Usually the start cases are 7:30, and so it's just to tell you. A lot of times we'll tell you either in a sandwich model, which is we'll tell you something good that we liked about your presentation, and then we'll sandwich it with something that you can improve on, and then give you another good compliment about your presentation, like that's called the sandwich model. Or sometimes we'll give you feedback in the way that we'll talk about identifying the behavior that we think should be modified, and then talk about the impact of what happened, and then also intervention of how you can make things better.
Some chiefs give a lot of bread and not a lot of meat in the sandwich, and some chiefs give a lot of meat and not a lot of bread. And they all care about you getting better and you doing well and you learning. And so I think we're very good at giving a lot of feedback, and it's just maybe more direct than people are used to on another kind of service. So,
but surgery is great. You'll enjoy it. And I think the most important thing is we want you to come, when you rotate with us, come learn. Even if you don't think you're interested in surgery, both of us didn't come in thinking we were interested in surgery, so you never know. Keep your eyes open and see what happens.